I'm Mary Chrysos.
And I'm Alyssa Chrysos, Mary's mom. And Mary ended up with a heart transplant. She was diagnosed with restrictive cardiomyopathy as a 3-year-old. She had been showing some symptoms of some illness, kind of flu-like symptoms, and we took her to the pediatrician where they did an exam, and for sure she had pneumonia, but at that point the pediatrician suggested an EKG as well, that her heart didn't sound quite right. So from there, chest x-ray determined for sure pneumonia, and then the EKG raised some more concerns and red flags, and from there we met with the cardiologist, and eventually found our way to, at that time, Children's Memorial. It's now Lurie Children's Hospital, where Mary eventually ended up listed as a 1A for a heart transplant. Our practitioners at what at the time was Children's Memorial, is now Lurie Children's, were Dr. Paul and Dr. Gossett. Transplantation definitely changed our life. The new set of concerns and things to worry about, but it gave us hope, gave Mary an opportunity at what actually has been a very normal life. We've been very, very fortunate that Mary's been able to stay relatively healthy, attended public school, blended it, she was just a normal girl, a normal kid. She played soccer and softball, did competitive dance. So while transplantation has definitely changed things as far as, knowing long-term Mary's going to have to be on some medications that will affect her in other ways, it's given her, a second chance at a normal life.
I found out that I had PTLD because in May of 2023 I started showing some symptoms of just like nausea and feeling sick and like really fatigued, and I just felt really different and off. So we saw a GI doctor, and I originally got diagnosed with celiac disease, and I had my normal cardiology checkup, and that's kind of when the concerns were raised more because my issues were not getting better, hence the gluten-free diet. So they ordered a CT scan, and that's when they saw my lymph nodes were enlarged, and then they did a biopsy to come to the conclusion of the diagnosis of PTLD. I had to deal with PTLD in the way that my freshman year of college went all virtual. I actually got the call that I had PTLD the day before I was supposed to move into college, so the first week of being diagnosed was just kind of rushing to get everything changed from in-person to online so that I could do my whole freshman year online and live at home while also receiving treatment. My treatment for PTLD was a 6-course chemotherapy regimen, CHOP E. So it was 6 rounds, and each round was 3 days. The first day was 8 hours of chemo, and then the second and third day were 1 hour of chemo, and then after the 6 rounds, I got an auto stem cell transplant, which was my own cells, and I was in the hospital for about a month for that. Recovery from PTLD was more difficult than I was expecting. Just losing all the weight and before I was diagnosed, and then losing all the weight from the chemo, and then losing all the weight from the stem cell, it was just really hard to get my weight back up and become healthy again, at a full 100%. And also a lot of foods I just didn't really care for anymore because the stem cell transplant changes your appetite, so it just wasn't really something that excited me, I guess. Oh yeah, transplant and PTLD hasn't stopped me from doing anything. I've been able to travel. I actually am studying abroad through my college over the summer, going to Italy. I've been able to travel.
You went to college?
I was able to go to college finally.
Russia sorority.
It hasn't really stopped me. It's just been something that's always been pretty normal to me, just because I was a lot younger when I was diagnosed, so it's always just been a norm that I've had to take medication every morning and night, or a norm that I've had quarterly checkups and had to go to the doctors. Like, that's just always been normal to me because I grew up around it so young. A piece of advice I have for transplant families is that I would advocate for yourself, and that if you start feeling off or feeling like something's wrong, is to go to your doctor, go to the transplant team, because you don't want to wait too long for things to get worse and progress, and it's just better to get checked out and seen right away to make sure like you're just healthy. Right. Sorry. My life goals is to actually run a hospital or just work somewhere in the healthcare setting, but like more of like the business side. I'm currently a sophomore at the University of Illinois Urbana-Champaign, studying community health with a concentration in health administration, and it would be awesome to run Lurie Children's one day. Yeah. I plan on advocating for others by sharing my journey and my experiences and just educating others, because I feel like as a young adult, like transplant and PTLD isn't really talked about a lot. Like, I had no idea what PTLD was. So I feel like just sharing my journey and my experiences and what I went through, and just educating others to make it like for more knowledge for other people who have to go through it would just make it a lot easier for others.
Everybody. My name is Dr. Rosanna Folquiero, and I am a pediatric nephrologist, which is a pediatric kidney doctor. And I currently work at Inova Children's Hospital in Fairfax, Virginia, just outside DC. And today I'm here to talk to you guys about post-transplant lymphoproliferative disease or disorder, also known as PTLD. So these are the things I hope to touch on today. We're going to go through some background, some risk factors in pediatric transplant recipients, the role of EBV in PTLD development, clinical presentation of PTLD, diagnostic evaluation of PTLD, management strategies for PTLD, prognosis and outcomes, monitoring and follow-up care, hopeful strategies for prevention of PTLD, and a little bit of current research and future directions. Just a little note before we begin. So at present, there are no consensus guidelines for monitoring of at-risk patients or optimal management strategies for pediatric patients with PTLD. Current literature is limited to case series and small studies, and many practice patterns for treatment are adopted from the adult literature. If you or a family member has been recently diagnosed with PTLD, you may have been quoted different statistics than what you see here in this presentation. This is related to inconsistencies in the literature, so please defer to the guidance of your transplant and oncology teams. Early recognition of risk factors with close attention to prevention efforts and prompt intervention is going to be paramount for improving survival. With that, let's begin. So, as I already mentioned, PTLD stands for post-transplant lymphoproliferative disease or disorder. This is the most common malignancy complicating solid organ transplant in children. The incidence of PTLD varies based on allograft type, and statistics may vary based on published data, so these ranges are just estimates. But liver transplant risk of PTLD is about 1 to 2%, kidney transplant 1 to 3%, heart transplant 2 to 6%, lung transplant 2 to 10%, and then intestinal and multi-organ transplant 5 to 20%, with some reports as high as 11 to 33%. PTLD accounts for only a minority of secondary cancer in hematopoietic stem cell transplant patients who only have a risk of 1 to 2% of developing PTLD. PTLD has a bimodal presentation. So there's early PTLD, which typically presents within the first 2 years after transplant, and late PTLD, which typically presents 5 to 10 years after transplant. Most cases are early and related to Epstein-Barr virus infection. From here on out, I will be referring to Epstein-Barr virus as EBV. And over 80% of pediatric cases present in the first year post-transplant during the most intensive period of T-cell immunosuppression. And I'll go into that a little bit more later. So principal risk factors for PTLD are really twofold. So EBV negative recipients of EBV positive donor organs and the intensity of T cell immunosuppression after transplant. Both of those taken together are responsible for over 90% of pediatric cases of PTLD. And we know that EBV plays a very big role in the development of PTLD. So how does it do that? Well, EBV infection is much more common in adults than it is in children. 90 to 95% of adults will have serologic evidence of EBV infection and evidence of acquired immunity at the time of transplant. So this is something we can figure out with a simple blood test. Children are more likely to be EBV negative. So they may acquire EBV from the donor organ, or they might develop a primary EBV infection post-transplant. One study of 276 pediatric kidney transplant recipients showed that EBV negative children who received organs from EBV positive donors were 6 times more likely to develop PTLD. And these rates are variable but similar in other solid organ transplant patients, where EBV negative recipients of EBV positive organs are more likely to go on to develop PTLD. You might see this abbreviation in the nomenclature where the D is positive and then R negative, and that just means that the donor is positive for PTLD and the donor is positive for EBV and the recipient is negative for EBV. And of course, these patients are at the highest risk, as we know. So both primary EBV infection in EBV negative patients and also reactivation of EBV infection in EBV positive patients who have latent, which means like sleeping or dormant EBV infection in their bloodstream can lead to PTLD, but it is much more common that you would see primary EBV infection causing PTLD than reactivation of old EBV going on to cause PTLD. But it's just important to know that patients who have reactivation of EBV that was previously latent or asleep in their bloodstream may also be at risk for developing PTLD. So how does it happen? This is an oversimplification, but I was hoping that maybe some pictures could shed a little bit of light on what is actually going on in the body. So B cells are cells that work in our immune system. These are just examples of your B cells down here. So the B cells become infected with this EBV virus. You can see the strains of red down here, either from a primary EBV infection or a latent infection like we discussed. And that goes on to cause cell proliferation, which is multiplication of infected cells, also known as a polyclonal expansion. And so you have this multiplication of cells, your immune system cells that have been infected with EBV. In immunocompetent patients, in patients who are not immunosuppressed, when the EBV is expanding in these certain cells in the bloodstream, there are other cells in the bloodstream that help us fight our EBV, called EBV-specific cytotoxic T cells. And in immunocompetent individuals, those cells are also multiplying, and they go on to proliferate and they attack the infected EBV cells and they eliminate those EBV cells from the bloodstream, and that's how they manage the infection. In the setting of high-dose T cell immunosuppression, such as thymoglobulin post-transplant, the function of these cytotoxic T cells, which help us fight our EBV-filled cells, is diminished. So we have much less cytotoxic T cells. I'm not sure if you guys can see that or if my face is over it, but much less cytotoxic T cells to help us combat these EBV infected B cells. And so the EBV infected B cells just multiply out of control. And that is what leads us to developing PTLD. So that being said, not all patients with high EBV viral loads will go on to develop PTLD. 20 to 30% of PTLD cases are not associated with EBV, and that's what's known as EBV negative PTLD. The pathogenesis of EBV negative PTLD is not well understood. It usually presents later, typically 7 to 10 years post-transplant, and this complicates monitoring protocols and management strategies for patients with EBV viremia because we just don't know if PTLD is eventually going to present in these patients and how often we need to be monitoring for it. So the clinical presentation of PTLD. The signs and symptoms are highly variable. They range anywhere from being asymptomatic to life-threatening disease. And again, that's what makes this so challenging. So usually your presentation depends on the type of PTLD and the organs that are involved. Most of the time, there are very non-specific symptoms. Again, this is what makes it so hard. There can be a little bit of fever, some fatigue, some weight loss, night sweats. Sometimes it looks like infectious mononucleosis or another viral syndrome. There might just be sore throat, some sinus symptoms. You might see swollen lymph nodes like lymphadenopathy. But in general, there isn't always an apparent abnormality on the outside, which is why this talk is so important and why PTLD should always sort of be in the backs of our minds, especially in kids who have high EBV. Sorry, PTLD should always be in the back of our minds, especially in kids who have high EBV viral loads. So more than half of PTLD will eventually present with extranodal masses in various organ systems. So most of the time, 60 to 70% of the time, these masses are in the abdomen, usually in the GI tract, like in the stomach or in the intestines. Sometimes they can be found in the liver. At times they can be found in the lungs, in the chest, 45 to 65% of the time. Masses can be found in the head or the neck, 20 to 30% of the time. In the central nervous systems, more specifically in the brain, and very rarely in the spinal cord, 20 to 25% of the time. There may be evidence of primary graft dysfunction due to infiltration of PTLD into the primary graft. So there might be evidence of kidney failure, heart failure, respiratory dysfunction, depending on what type of solid organ transplant the patient has. And then there can also be evidence of secondary organ dysfunction from mass compression of the surrounding structures. So the initial evaluation for possible PTLD depends on the presenting symptoms and the clinical scenario. So these are lab tests that can be done and then possible associated findings that may suggest the presence of PTLD. So CBC, which is just a routine test looking at our blood counts, may show low blood counts. So that would be anemia, which is low hemoglobin, thrombocytopenia, which is low platelets, or leukopenia, which is low white blood cells. And you can see any or all of these. You might see an elevated serum lactate dehydrogenase or an LDH level. Your team will look at a chemistry panel, which will have electrolytes, liver function, kidney function. There may be abnormal kidney or liver function depending on the graft or depending on secondary organ involvement. These numbers could possibly be normal. There may be evidence of high calcium levels, which is often associated with underlying cancerous processes. And then there may be evidence of something called hyperuricemia, which is high uric acid levels in the blood. Anytime a clinical provider is suspicious for an oncologic process, whether it's in a transplant patient or not, these tests are routinely ordered. So these are not special tests that you need to ask for. Any transplant team would know to look for these things if they were suspicious for PTLD or some other underlying cancer. So imaging tests and associated findings will suggest PTLD. So there can be radiologic evidence of a mass on any imaging modality. It may not even be the primary reason that the imaging is being done. It could possibly be a surprise on an ultrasound or on a chest X-ray. But patients who are suspected of having PTLD will undergo a CT scan of the chest, abdomen, and pelvis usually to look for where the tumor may be and to assess disease burden. Other imaging of other organ systems might be necessary based on symptoms. So again, PTLD in the brain is uncommon, but not impossible. So some kids who are having neurological symptoms may require a brain MRI. And then most patients with high suspicion for PTLD or possible confirmation of PTLD will undergo a PET scan, which is another imaging test that is often combined with the CT scan that shows metabolically active areas, which basically mean areas in the body that light up that could possibly indicate other areas of disease or assess disease activity. So sometimes you can see active areas on PET scan that have not yet turned into discrete tumors that you could see on a different imaging study, which is why this test is important because it can help us find areas that are sort of smaller and more hidden. So, of course, as we discussed, a big part of our suspicion for PTLD depends on your EBV viral load. So the EBV viral load is determined by something called a quantitative PCR test from the blood. If you have an elevated EBV PCR, that's the same thing as having an elevated EBV viral load, and that should raise suspicion for something called EBV positive PTLD. But just having high EBV PCR and a high EBV viral load by itself is not enough for a PTLD diagnosis. In order to have high clinical suspicion for PTLD, there's got to usually be something else. So some form of other symptoms that we had addressed previously, plus rising EBV levels in the blood, is usually enough clinical suspicion to say, okay, we need to do further testing in this scenario. Then those kids usually progress to imaging testing to look for a possible mass. And then a tissue biopsy with excisional biopsy of a suspicious lesion when possible is done. And that is what gives us the confirmatory diagnosis of PTLD. So we need a tissue sample that shows the abnormal cells. Again, as we have discussed, the absence of EBV in the blood makes PTLD less likely, but it does not completely exclude the diagnosis. So PTLD classification is based on biopsy. So as I sort of touched on earlier, the L part of PTLD is lymphoproliferative disorder. So what does that mean? That means there is proliferation, which is rapid production of abnormal lymphocytes. And so lymphoproliferative, you have proliferation of abnormal lymphocytes. And your lymphocytes are white blood cells. They are immune system cells. And because they've been most of the time infected with EBV, you have these sort of dangerous, thick lymphocytes running rampant throughout the bloodstream, throughout other organs, and that is what leads to PTLD. So there are four main categories of PTLD based on morphologic, immunophenotypic, and genetic features. Classification guides management and therapy. That's why biopsy is so important, because without a tissue sample, we aren't able to classify the PTLD, and then we aren't exactly sure the best way to treat the PTLD. So on the next slide, we're going to go through the four categories. It's really just for future reference. It's something you can look back on if you're looking for a primer on the types of PTLD. But I'm not going to go too much into the specifications of each category because that's beyond the scope of this presentation. I just want you guys to know that they exist. So the first category of PTLD are early lesions or non-destructive PTLD. So these are three different patterns of cell proliferation. So you've got lots of abnormal cells in your bloodstream, but the types of cells are considered to be early and they're considered to be benign. The remaining three types of PTLD are considered neoplastic or oncologic processes. Essentially, they are cancer. So you can have polymorphic PTLD, you can have monomorphic PTLD, which typically meets the criteria for other subtypes of lymphoma that you've heard about before, non-Hodgkin's lymphoma, Burkitt's lymphoma, diffuse large B-cell lymphoma. Or you can have type 4, which presents like a classical Hodgkin lymphoma-like PTLD. Basically, if we did a biopsy, it would look just like classical Hodgkin's lymphoma. A quick note on CD20. Again, this is very technical, but CD20 is a protein that's present on the surface of some of our immune system cells. So some, but not all, of these PTLD cells will express CD20. Those that express CD20 may respond to anti-CD20 treatment, such as rituximab, which we'll get to a little bit later. So I just want you to know that any of these types, polymorphic, monomorphic, or even the classic Hodgkin lymphoma-like, it differs from patient to patient, but sometimes they express CD20, and that means those patients are eligible for a certain type of treatment that other patients are not eligible for if their tumors do not express CD20. So overall goals for management of PTLD are eradication of PTLD and preservation of allograft function. Unfortunately, it's hard to do both of these things. One goal will take precedence over the other based on the needs for the patient. So a mainstay of PTLD treatment involves reducing immunosuppression. But as we all know, if we take the immunosuppression away, we're increasing the risk of graft rejection and failure. The specific therapy will largely depend on the PTLD subtype, if you have type 1, 2, 3, or 4. And the nuances within those therapy plans will vary from institution to institution. Just another little note. So I am going to briefly review the most common treatment strategies, their indications, and the risks benefits to each approach. But this will ultimately depend on each patient's specific circumstances and the multidisciplinary team's approach at the institution in which they receive their care, with lots of guidance from the oncology team, the primary transplant team, and other subspecialists as necessary. So let's review management strategies for PTLD. Reduction in immunosuppression, or RIS. This should be incorporated into the initial management of all patients with PTLD unless concerns regarding graft rejection make this unfeasible. So again, it's all about that balance, right? Are we worried more about trying to treat the PTLD or trying to prevent graft rejection? The answer is different for every single patient. The goal is to bring back that EBV immunity. Remember those cytotoxic T cells that had been completely depleted? The goal is to bring back that part of the immune system to try to help our bodies fight the PTLD and fight the EBV. So the goal is to bring back those cells in the immune system without increasing the risk of rejection. So typically, and just broadly, immunosuppression is generally reduced to the lowest tolerable level. And at times it can reach 25 to 50% of original baseline therapy. Of course, there are no specific protocols for how to do this, and the optimal reduction strategy is unknown, but in general, many centers begin by reducing calcineurin inhibitors like tacrolimus, their trough goals by 50%, because there is a whole host of published literature regarding this interplay that back in the day when we used to run the tacrolimus troughs much higher, there was higher levels of EBV viremia and higher cases, more likelihood of developing PTLD. So having that knowledge, typically centers will reduce the tacrolimus trough goals first. Then anti-metabolite therapy like mycophenolate mofetil, also known as MMF, also known as Cellcept, or azathioprine. Those medicines will typically be reduced in parallel or after the tacrolimus is withdrawn. Again, it just depends. And then there's variable reduction or withdrawal of corticosteroids based on center preference. Certain kidney transplant protocols already offer a rapid taper of steroids post-transplant. There are some protocols that are steroid-free to begin with. So again, this is center dependent, and this all plays into your center's decision on how to taper what and when. So does reduction of immunosuppression work? Some studies suggest that if you have that type 1 PTLD, those early lesions that are technically benign, there are studies that suggest that there may be early resolution of those lesions with reduction of immunosuppression alone, sometimes as rapidly as within 3 to 5 weeks of starting the reduction. Other studies suggest that many patients go on to need more therapy. The caveat to this, of course, is that up to 50% of patients may have evidence of organ dysfunction or graft rejection during the reduction of immunosuppression phase. As we know, data in children is very scarce. Some adult solid organ transplant studies claim rates of complete response rate of 37% from reduction of immunosuppression alone. But in the exact same study population, there was also a 32% rate of acute rejection in that same study population. So it's all about balancing risks for each specific patient. Reduction in immunosuppression alone may not be enough to eradicate PTLD, but early reduction of immunosuppression in the setting of increasing EBV viral loads before you get to PTLD might prevent progression to PTLD. So in general, if it applies to the patient and if it works for the patient, reduction of immunosuppression is still first-line management in patients who are both at risk for PTLD and who have confirmed PTLD, if it's feasible. So immunotherapy with rituximab. Rituximab is a reasonable option for patients who have that CD20 positive PTLD, who continue to have evidence of residual disease or PTLD despite reduction in immunosuppression, or for patients who are not a candidate for reduction in immunosuppression. So as we discussed briefly before, not everyone is going to have CD20 positive PTLD. So this medicine only applies to people whose PTLD is found to express CD20. And that's something that we look at when we do the biopsy of the affected lesions. So rituximab can be used by itself or it can be used in conjunction with chemotherapy, depending on the clinical scenario. Of course, there are no guidelines for who would benefit from both. And if somebody needs both, do they get one and then the other? Do they get them both together? What should the plan be? There's no real guidance on that. Adult studies have shown a response rate anywhere from 44 to 79% with rituximab alone, and complete remission rates in 20 to 55% of patients. Again, very little data for outcomes in peds. One small study suggested complete remission in 70 to 75% of pediatric solid organ transplant patients, which of course sounds promising, but we always have to take a step back and realize, okay, well, there were only 18 out of 21 patients in the study. So great numbers, but of course we need more data. So patients who have CD20 positive PTLD might receive chemotherapy in conjunction with rituximab, as I mentioned before. So that is called R-CHOP. So the R part is rituximab, and the CHOP is for these other 4 agents for chemotherapy. I know the acronym doesn't make sense here, but doxorubicin and vincristine, some of their brand names actually start with H and O. So that's where the R-CHOP comes from. Again, ideal timing of therapy remains unknown. Many suggest adding chemo in patients who don't achieve an adequate response or complete remission after the initial treatment with rituximab. There was one phase 2 clinical trial in pediatric EBV positive, CD20 positive PTLD, which showed a complete remission rate of 69% in kids who got rituximab, and then cyclophosphamide and prednisone. So that's sort of like a modified R-CHOP protocol. They didn't get all of the agents there, which showed a 2-year event-free survival rate defined as children who were alive with a functioning graft and no evidence of PTLD of 83%. So patients who have CD20 negative PTLD don't need anti-CD20 therapy with rituximab. So patients who have CD20 negative PTLD or patients who are not candidates for rituximab might receive the CHOP chemotherapy alone. And patients who have classical Hodgkin lymphoma like PTLD will receive chemotherapy in accordance with Hodgkin's lymphoma protocols. So there's no variance there usually. Again, if I can't drive this one point home enough, the data for use of chemotherapy in PTLD in pediatric patients is still limited. There are no randomized trials comparing chemotherapy regimens in PTLD. Some patients may require other regimens at the discretion of their physician or based on their personal risk of side effects. And of course, indication for and selection of additional agents is beyond the scope of this presentation. So this should be discussed with your friendly oncologist and transplant team. Radiation or surgical therapy is like local management of therapy, mass reduction, et cetera, by surgery or radiation. This is limited to rare situations. Usually if a patient requires treatment of local disease due to compression of surrounding structures, symptomatic control, again, are they having symptoms because they're having compression of a mass in their belly, causing them to not be able to eat, or for palliative care purposes. In disseminated or central nervous system disease, like in the brain or spinal cord, some patients may need radiation in conjunction with chemotherapy. Again, it all just depends on the patient's circumstances. Sort of a newer, more up-and-coming therapy is adoptive immunotherapy with something called EBV-specific cytotoxic T cells. So this is an adoptive cell therapy that involves transferring naturally occurring EBV cytotoxic T cells, those cells that we know get downplayed because you have T cell immunosuppression on board, so your cytotoxic T cells are depleted. We can actually put those into you to kill the EBV infected cells in patients who have EBV positive PTLD. So this is gaining popularity in solid organ transplant patients in the last decade, especially in patients with treatment refractory PTLD. Again, use in pediatric solid organ transplant patients is limited. Published results show an 80% remission rate, so 8 out of 10 children, and survival rates of 89% at 2 years and 86% at 5 years in solid organ transplant recipients who received these EBV-specific cytotoxic T lymphocytes for management of their refractory PTLD. So a major benefit to these is the potential to combat PTLD while avoiding immune ablation and organ toxicity that is sometimes seen in chemotherapy. This therapy is not currently widely available and typically reserved for patients with PTLD that is refractory to other treatments. So now we're going to move into prognosis and outcomes, monitoring and follow-up, prevention strategies, and then current research and future directions. Prognosis and outcomes. So published data in all pediatric solid organ transplant patients suggests several parameters associated with poor prognosis, which I'm sure will make sense to you guys. So if you have multifocal and extranodal disease, if you have involvement in your CNS, in your brain or spinal cord, if you have involvement in the primary graft, or if you have a very high EBV viral load at the time of diagnosis, that can all be associated with a poor prognosis. Morphologically, if you have EBV negative PTLD, if you have CD20 negative PTLD, if you have the monomorphic subtype of PTLD, which is where your PTLD looks like a different type of cancer, like Burkitt's lymphoma, diffuse large B-cell lymphoma, etc. If you have late onset disease, and if you have a poor response to initial therapy, all of those are factors that are associated with a worse prognosis. I know everybody wants to know about the mortality rates. Mortality rates are really hard to extrapolate, and I caution you when you look into the literature yourselves. It's hard to extrapolate mortality rates because the sample size is so small. We're very lucky that PTLD is so rare. And there's various levels in these studies of disease burdens, of organ involvement, of other comorbidities. Again, the data in the adult literature, adults are much more fragile, much less resilient than children. And so they may have increased risk of morbidity and mortality from PTLD, not related to the PTLD itself, but related to other things that they have going on. Overall, children have a better prognosis than adults. Survival data in kids is limited, again, to these small case series and studies across all graft types, all types of PTLD, so it's really unfair to lump them all together. But in general, the reported 5-year survival rates are estimated at 53 to 80%. So what can we do? What sort of monitoring and follow-up can we do? EBV monitoring is part of routine post-transplant care in most patients. Centers are going to differ with regards to their definition of high-risk patients and the cutoff used to determine EBV positivity. Since most EBV positive PTLD is going to occur in the first year after transplant, it's reasonable to monitor high-risk patients more frequently initially, and then space out testing as they get farther and farther out from transplant. Of course, the decision to monitor less frequently has to be individualized. It has to take into consideration many factors, including the type of the graft, the degree of ongoing immunosuppression, and the pattern of EBV viral loads up to this point. Is it safe to start checking the EBV less frequently, or do we need to continue checking it at a certain rhythm to make sure things don't go off the rails? So even in this very fancy document, this is the IPTA, which is the International Pediatric Transplant Association, Nashville Consensus Conference on PTLD after solid organ transplant in children. This lovely group in January 2023 published consensus guidelines for EBV load and other biomarker monitoring. And even in the consensus guidelines, they could not reach a consensus. So in higher risk patients, monitor the EBV more frequently. This may be as frequent as weekly for the first 3 months, every 2 weeks for the next 6 months, and monthly thereafter. Again, there's no existing protocols that are superior to other protocols. It's just monitor it frequently if you suspect that things are not going in a favorable direction. In lower risk patients, those patients are monitored less frequently, monthly for the first 6 months, then every 3 to 6 months thereafter, and eventually yearly, unless concerns, symptoms, or other things arise. Of course, if the EBV load is noted to be rising, the monitoring should become more frequent, like every 2 to 4 weeks. But again, this is center dependent, so I defer to your transplant team. Of course, the benefit to frequent monitoring is that it allows for an earlier opportunity for intervention and preemptive treatment with increased likelihood for favorable outcomes. So the message here is always, early and frequent monitoring is better. That being said, there's always a balance against patients who are high risk and patients who are low risk. And what I don't want to do is induce too much anxiety. If it's a low risk patient with, low chance of developing PTLD, they're 1 to 2 years post-transplant. There have been no concerns for high levels of EBV viral DNA, high levels of EBV in the blood. Yeah, I don't want you guys to run to your transplant teams and say, Dr. Fulgara said we should still be checking every 3 months. It's there is a balance between like maintaining quality of life and then also making sure we don't miss something. So if your patients are low risk, then it is reasonable to monitor them less frequently than if your patients are higher risk. And I will say, in my personal experience, most transplant centers are always going to err on the side of caution and check more frequently until they see levels stabilize or improve. So maintaining close contact with your transplant team at the recommended intervals is also beneficial for early detection. In addition to monitoring the EBV viral load, engaging with your transplant team offers the opportunity to check in on new symptoms that may not seem overtly obvious, like fatigue, weight loss. There may be other subtle physical exam signs, like a swollen lymph node or other laboratory indications for PTLD that just might not be on your radar. Sometimes having someone say, hey, are you more tired than normal? Hey, have you noticed any unexplained weight loss? Sometimes as kids get older, they get more busy, they're playing sports, they're going to school. This just isn't necessarily on the top of everybody's list. And so having someone else ask you those questions and bring those things to light is sometimes helpful to sort of red flag things that maybe we wouldn't have originally thought about. The same lovely International Pediatric Transplant Association Consensus Conference also made recommendations on guidelines for prevention of PTLD. So these are some hot topics that were discussed, and I'll touch on them a little bit more in the next couple of slides. But essentially, the three big ones are reduction in immunosuppression, antiviral prophylaxis or preemptive treatment of rising viral loads, and then other therapies like an EBV vaccine, giving prophylactic IVIG prior to transplant, giving prophylactic rituximab right before transplant, post-transplant, or when they notice the EBV viral loads are going up. Those three things in particular, there's not enough evidence to support the use of therapies at this time. It doesn't mean they might not be done at your specific institution. When I say there's not enough evidence for something, it means sometimes there is evidence that some of these therapies could possibly be favorable, could possibly reduce risk of PTLD. There might also be evidence that some of these therapies didn't work. So it doesn't mean that these therapies are necessarily harmful, but in the next couple slides, I'm going to say at times there's just not enough evidence for it. It doesn't mean that it's not something that could possibly be attempted. So again, reduction in immunosuppression. So in general, we have come a long way in post-transplant immunosuppression in the last 20, 30 years. So our current practice patterns for any patient are going to be as outlined below. So usually everybody, most patients, regardless of solid organ recipient type, patients get high level induction immunosuppression immediately post-transplant to decrease our body's immune response to the graft, right? This prevents early rejection. Over time, as the risk of acute rejection decreases, chronic immunosuppression is reduced accordingly to promote long-term graft survival and reduce long-term toxicities. So in general, in the last 30 years, current practice patterns have already focused on minimizing overall immunosuppression in all organ recipients in general for many improved benefits and outcomes, which is also favorable for reducing the risk of PTLD. So this is general practice patterns have already changed in the last 20, 30 years. But then further reduction of immunosuppression in response to elevated or rising EBV viral load is recommended to prevent the development of EBV disease, including PTLD. Technically speaking, there is only strong evidence for reduction of immunosuppression in pediatric liver transplant patients. That doesn't mean that we don't do it in other solid organ transplants. It's just that technically speaking, there is not enough published data for reduction of immunosuppression to prevent PTLD in other solid organ transplant patients. This makes it challenging for me to sit here and say, we absolutely need to reduce immunosuppression in all solid organ transplant patients because technically speaking, there isn't strong evidence for that, especially given that the risk of rejection may be higher when immunosuppression is reduced in certain solid organ transplants like heart, lung, and intestinal transplants. The consensus group asked this very popular question: is there some role for post-transplant antiviral therapy like acyclovir, valacyclovir, ganciclovir, or valganciclovir in prevention of EBV disease, including prevention of PTLD? So in vitro studies, like in test tubes in the lab, these drugs do suppress the replication of EBV. But this does not translate to suppressing the EBV cell proliferation that you see in vivo, meaning in animals and in people. So there is insufficient evidence at this time to say, hey, let's put everybody on some antiviral medicine for X number of months post-transplant to prevent EBV, to possibly prevent PTLD. There's also insufficient evidence to support using these antiviral medicines once the EBV viral load is rising. So when we start to see the EBV viral load going up, there's not enough data to say, hey, we should give antiviral medicines at this time to try to bring the EBV load back down. So current research and future directions, I don't know if my face is over the top corner or not, but this company called Atera has developed this therapy, which I cannot say, but is lovingly abbreviated as tab-cel. And this is essentially this is a therapy that was studied several years ago in something called the ALLELE trial, which was a global, multi-center, open-label study. And the early results from this study were published in March of 2024. And what this showed was that adults and children with EBV positive PTLD, this medicine was given to patients, adults and children with EBV positive PTLD who did not adequately respond to treatment with rituximab with or without chemotherapy after hematopoietic stem cell transplant or solid organ transplant. So patients were treated with tab-cel by IV infusion weekly times 3 doses. Some patients got 1 round of this, some patients got 2. And in the preliminary data of the 75 patients enrolled, 51% showed at least some response in their PTLD, and 28% showed complete response. So that's 7 out of 14 stem cell transplant patients and 15 out of 29 solid organ transplant patients. Regarding adverse outcomes, there was some evidence of disease progression in some patients, and there were also some non-treatment related patient deaths. Overall, the authors interpret that tab-cel provides clinical benefit in patients with relapsed or refractory EBV positive PTLD for whom there are no other approved therapies. Because the results of the ALLELE trial were so promising, a proposal was submitted to the FDA for approval of this medicine in July 2024 and is under review as of January 2025 for the primary indication of adult and pediatric patients 2 years of age or older with EBV positive PTLD who have received 1 or more prior therapy, including an anti-CD20 containing regimen like rituximab. Currently, this medication is only approved for use in the European Union. In the meantime, there is an open label phase 2 study ongoing, though not recruiting new patients, evaluating the safety and efficacy of this tab-cel medicine for other EBV-associated diseases, including EBV-positive PTLD in the central nervous system, that is, again, relapsed or refractory, or newly diagnosed central nervous system EBV PTLD, or EBV positive PTLD where the standard first-line therapy like rituximab or chemotherapy is inappropriate, and this is including CD20 negative PTLD. So some key takeaways. I don't know if I could have emphasized this more, but at present, there are no consensus guidelines for monitoring of at-risk patients or optimal management strategies for pediatric patients with PTLD. Close follow-up with your transplant team is important, as is having blood work checked at the appropriate intervals. You know, if you miss an every 3-month blood work check, then you go 6 months without having your blood work checked, and a lot can happen in 6 months. Pay attention to any subtle signs or symptoms. I don't want this to make you crazy. I don't want you to worry every time you or your child has a sore throat that maybe that means they have PTLD. But especially if the EBV viral load is rising, it's important to pay attention to these subtle signs or symptoms that may not otherwise be on our radar. New medical advancements are happening every day, so it's always reasonable to ask your transplant team for a second opinion, to inquire about current clinical trial availability, or to investigate other experimental therapies. It's never wrong to advocate for yourself or for your child and to ask these questions. And then, of course, early recognition of risk factors with close attention to prevention efforts and multidisciplinary collaboration at your local institution is essential to improve outcomes and provide the best possible care for our children. And that, these are all of my references. It was such a pleasure speaking with you guys today. I should be around during this talk and hang around after, so I would be happy to answer any questions that you have in the chat. Have a great day.
I tried to address most of the questions in the chat. You guys are an extremely intelligent, savvy group, so I knew there were going to be questions that I would not have the answers to, and I do apologize for that. I'm happy that people think that this is digestible information. I did do my best from that standpoint. I was trying to understand a little bit better the question about maternal antibodies. How is the risk for PTLD affected if the receipt of the EBV positive pre-transplant is suspected to be maternal antibodies? So I just didn't fully understand the question, and I don't mean to call you out. You can message me maybe privately in the chat if you want to discuss it further. But I just want to know, I was trying to address everybody, so I was just stuck on that one. So I do plan to provide you an answer if you want to message me on the side, or if, I don't know if she's allowed to message me on the side, Melissa, but if she can, we could talk about it further. There is another specialist that will come forward to discuss EBV. I'm not an infectious disease doctor, but there is an incredible one who's present today. So she will be, I think that Melissa will also bring her forward so that she can answer those questions to explain what EBV is. I think she's probably more eloquent about that than I am, but I'm happy to answer any other general PTLD questions you guys may have.
Thanks so much, and it's my pleasure to introduce Dr. Hill Sargent, who's with us, and conveniently an ID doctor, so thank you for jumping in. This is a great discussion, and we're so glad to have you with us.
Thanks. So somebody asked, what is EBV? So EBV is a type of herpes virus. So herpes viruses, there's many different ones. You've probably heard of herpes simplex virus. And the thing you might know about herpes simplex viruses is it causes cold sores that come out during times of stress. Similarly, all herpes viruses hide in your body and can come out during times of stress. So for EBV specifically, it hides in those B cells, as was discussed. And when your immune system gets weakened, and that can just be from stress or from more immunosuppression, be it from rejection treatment, or even just from another infection, like somebody was talking about other viral infections, that can dampen your immune system. Then the EBV can come out of hiding or latency. And that's when you can actually have reactivation and sometimes proliferation of those B cells. And so EBV itself is just one of many herpes viruses. Other ones you might have heard of include actually varicella virus, or CMV is another one. So that's what EBV is. Feel free to ask more clarification if you want.
We also had one more question. Let's see. Transplant patients with a lot of chronic illnesses, are they more high-risk patients, are likely to get EBV?
I think Taylor can probably comment on this too, or sorry, Dr. Hill Sargent can comment on this too, but actually you unmuted, you should comment. But my sense is yes. With the degree of immunosuppression, my sense is yes, but please feel free to answer that.
Yeah, I think it all depends on how much, if your immune system is impacted. And it's always a struggle with any of these herpes viruses. So you mentioned CMV cytomegalovirus. Thanks for clarifying that in the chat. All of these, sometimes they come out and you don't know if it's actually causing an issue or if it's just there because you're having a reactivation from for another reason, that your immune system is down for another reason. So if another chronic illness is something like kidney failure, where you might have decreased immune function from that itself, then maybe yes. But I think what I'm sorry, I'm going to mispronounce your name, Fulcherio, was talking about, how there's just a lack of data. We need to understand this better. And understanding the risks of PTLD specifically is something that we need to work on as a community.
I'm actually wondering if you maybe have thoughts. One of the moms in the chat was saying her 8-month-old son tested positive for EBV antibodies, which they anticipate is maternal. And so the question is, he's going to have a living donor transplant next week. Like, is he technically a positive? Like, is he technically EBV positive, or not? My sense is yes, but again, this is sort of up your alley. Like, if he's testing EBV positive, it doesn't matter where it came from. He is positive for the antibodies, but you would again know better.
It's a tricky question. And the problem with it is, since he's 8 months, he still has a lot of those maternal antibodies in his system from when they crossed over in the placenta when in utero. So when we do the test, we aren't able to tell if they're mom's antibodies or his antibodies. So that's why sometimes in kids that young, it's almost not a useless test, but it's not as clarifying as we would hope. If it's negative, that might help us, because then we can know, yes, it's not mom's antibodies because they're not there and the baby hasn't been exposed. But if it's positive, there's no way for us to tell. And so we'll usually err on the side of just assuming there's a risk there that he could have had it pre, or it doesn't change because it's EBV as much as what we do, since there's no prophylaxis, as was mentioned. But it's not as helpful as if it had been negative. It's not an answer that we'll probably be able to tease out.
Dr. Hill-Sargent, I'm providing your prior talk that you had with us from our YouTube. I'm going to put that link in the chat, and I will let you both continue answering questions.
I have not heard of a connection between BK virus and PTLD. I hate BK virus, and it's one that comes out when the immune system is not working properly. So I could see how there might be an association, but it might not be causative or causal, where one might not lead to another. But I would caution, don't, just because somebody has another infection, has a BK virus, any of that stuff, even if you see EBV, that doesn't mean you're going to have PTLD. We see these blips, these rises all the time, and that's for us to worry about and us to screen and us to think about. It's not for you to sit there and perseverate over the numbers, because there are so many reasons they could be going up, and we have to figure that out. That's on your medical team.
I agree completely. I was trying to get the same point across. I don't want everyone to think if your child has like rising EBV PCR and you have a sore throat, that immediately it means we have to worry about PTLD. And to Dr. Hill-Sargent's point, like, it is on the medical team to make sure that we are continuing monitoring. It is always on behalf of the family members to ask questions if you feel like things are possibly falling through the cracks. But I don't want this to keep everybody up at night, because the risk is still, when we take a step back and we look at the percentages, the risk is still very, very low, overall. So your transplant teams are aware that this is a possible outcome, and people know to continue to monitor the EBV PCR levels if they're going up. So yeah, I don't want everyone to be worried. Like, if all the labs look good, I don't want you to be sitting at home waiting for the other shoe to drop. It doesn't just come from nowhere. It's not like you wake up one day with PTLD. There should be signs in the blood work leading up to that point in time, ideally.
We have a question in the chat about relapse information. Is there any data on that?
Unfortunately, it hasn't been updated at all. Again, because the sample size technically is so small, so many different types of PTLD, so many different organ transplants, different types of solid organ transplants, different immunosuppression situations. There's just no updated data on relapse rates. It's too hard to conclude who will relapse and why, just because every patient in every case is so different. So sorry, Brandy.
I will go ahead and conclude from here. We're going to pass questions forward. Dr. Hill Sargent, thank you for letting us phone a friend. I love this community. I love that we have so many clinicians on and so many that volunteer with us, and we're just grateful for that. Dr. Fulciero, thank you for being with us. This is by far the most thorough presentation we've had on this so far. So a lot of us parents are immensely grateful for it. So I can't thank you both enough.
Thanks for having me, guys. I was honored to be here. Take care.
You too. Everyone stick around. Our next session is in about 20 minutes, but you got a nice long break. So grab something to eat, come back and stay with us through the rest of the day. Bye.